sick, and that's very important. The cone beam, we take it in for 3.5 years. Our department is exceptionally well, and we really profit from each other. And then you see how that was done. In such a case, I normally use a BLT implant because it helps to optimize the primary stability.
To improve the
stability. Now, one point I have to mention here, you see that this implant, as when you look here, is rather deeply placed because this implant has a micro rough surface all the way up, and in an immediate implant placement, you always get a remodeling on top of the alveolar bone. This is just a reality, and therefore I go deeper. I'm waiting urgently to get from Straumann a so-called TLT implant, or like a tissue level type bone level tapers, because then we get on top a machine surface, and then I don't have to put them as deep as we did in this case. So here everything heals very nicely. The soft tissue conditioning is done by the crown, of course. The crown is out of occlusion. 3 months we don't touch that crown. Then we take it off, take an impression, go for the final restoration, and here you see excellent outcome for this patient. Another case we did already in 2017. You see here the whole setup, same procedure, internal grafting, and then the provisional done by Julia Wittneben. Here you see the 2-year follow-up, including a cone beam that shows that the facial bone wall is fully maintained, regenerated inside the bone. So I'm very, very pleased with this.
Good. So after knowing this background, clinical and scientific background, what are the advantages that you consider an implant placement has, and how often do you use it, this protocol?
Okay. First of all, I have to say my surgical experience is limited to 3 years. In this period, I have treated about 20 patients. That's not a lot. So that is somewhere between 5 and 10% of implant replacements in the aesthetic zone. Most of the cases have been done in premolars, in first premolars, because there you find more often a thick facial wall. So I'm very pleased. What I see in 20 cases, we had in one patient a biologic complication, 1 out of 20. So that's okay, that's acceptable. The patients, of course, like it very much because they have almost no problems. They have always a fixed restoration. So I see that this is a very nice treatment option, although there is a lack of good long-term data, to be honest. So I think it's still a demand to build up the long-term documentation with the current techniques. So that's probably very important.
Okay, that's a good final message to share with all the colleagues around the world. So moving to the second topic, if you agree.
Yes,
that is early implant placement. That it's, I mean, like a signature for you, for your team, for your lectures. Tell me or share with us when and how do you consider that early implant placement is the best option to face a clinical situation?
Okay, so first of all, I think we can say early implant placement is really a very good option. We have excellent long-term data, as I will show you later. We use that technique, and the technique is that we do it 4, 6, or 8 weeks post-extraction, what you see here.
Good.
So, when it's a small tooth, a lateral size, it can be 4 weeks enough. When it's
so early implant placement means that the implant...
8 weeks.
Okay, so the implant will be placed 4 to 8 weeks
post-extraction.
After the extraction. That's good.
Exactly. Yeah. You see, and the indications are then when the facial bone wall is thin, or when the facial bone wall is not there. It's already damaged due to infection from a tooth or so. We also need to have enough bone volume to stabilize the implant, and you need a 2-wall defect 6 or 8 weeks later. For that one, we measure, as you can see here, we measure always the width of the crest when we do the extraction, also what you see here, we measure
Yeah.
this. And when I measure that, I know 6 or 8 weeks later, I'm going to have exactly this
Good.
millimeters stress width, because that does not change in such a short period of time.
Good.
So that's where we use it. And of course, in the aesthetic zone, that's 85% of our cases. It's a very it's a very nice indication. And as I will show you, it's not difficult to do. It's much less problematic than an immediate implant placement, but that's a disadvantage. It's an open flap procedure. You cannot do that flapless. The facial wall will be resorbed, so there will be a defect. And when you do the implant surgery, then you have to rebuild the bone.
Okay, so you don't socket graft after or immediately with extraction. You just do the extraction and let the nature to heal the site.
That's a very good question. You see, I often get this question, and I tell you, in a routine case, you don't do a socket grafting. I will explain that to you. Why? You see, the procedure has been described in this paper in 2008, and the case that has been shown.
Yeah.
So there is an extraction. When you do an extraction, then it's flapless extraction, and you degranulate the sockets.
Yeah.
Then you put in there a collagen plug to stabilize the clot. But you don't put in there a socket graft like Bios or something else.
Okay, no bovine material, no bone, nothing.
No, I will explain to you why. Because what's happening here, you see an animation video we have on our YouTube channel also available.
Good.
So flapless extraction, degranulation, and then you put in a collagen plug, and the collagen plug only stabilizes the blood clot to allow a good soft tissue healing.
Okay, that's the reason. That's it. That's
what happens, you see? Now, in the first 2 weeks, you get the bundle bone resorption described by Araujo. And you see, in a case like this, you get this crater-like, typical crater-like defect. And what you also get in this early phase, you get primarily a soft tissue healing in that socket. In the crestal area of the socket will be ingrowth of soft tissues.
Yes.
And of course, it's not exactly what you see here, but of course, at the end, after 2 to 4 weeks, you get here a flattening, and you get here a lot of soft tissue inside the socket. Now you see immediately the big advantage you could have. When you go in 6 or 8 weeks for surgery and you cut here, then you have all these soft tissues part of your flap to the buccal. So this is actually, we call that an spontaneous soft tissue thickening.
Soft tissue grafting, exactly.
It was also described by Vivian Chapuis in a paper in Journal of Dental Research 5 years ago. And you see now here, again with our animation video, you go in slightly palatal. With the tip of your scalpel, you go to the inside wall of the socket, to the palate. And you go up all the way where then some bone formation might be detectable. And then when you mobilize the flap, you get there a thick soft tissue as part of your flap. So this is big advantage.
It's like an auto tissue graft, and you find a much thicker connective tissue on your flap.
Absolutely, and the beauty is that this soft tissue is vascularized. This is not a free mucosal graft from the palate. So this is much better. And of course, with this technique, we are having much less frequency for a soft tissue augmentation. That's Then what we do here, you see now from a patient, I show you with 4 video clips simultaneously. First of all, here how we do the incision, you see, and then the releasing incision here, and then how we mobilize the flap. And here you see this bulk of soft tissue thickness.
Yes.
Like a big chunk of soft tissue, vascularized soft tissue. So this is a thick biotype of phenotype mucosa.
Good.
During your implant surgery.
placement. Yeah.
Okay, now next. Next comes that we immediately take the blood and we immediately start to harvest the autogenous bone chips, the patient's own bone. That's something we learned in the last, that's about 5 years ago, 6 years ago, when we had some preclinical research data available and we realized that we had missed the chance many times. So you see where we take the bone. The bone is taken
Good.
apical to the lateral incisor, or we can
You
also take the bone at the nasal spine.
you don't open a donor side. You don't go
No,
further in.
no.
Good.
We don't have to have an additional flap. So this is something to minimize, of course, for the patient, the morbidity. You see
Morbidity.
the blood is here with some ringer solution and the bone goes into that blood ringer solution. What
Yeah.
happens, I will show you that actually the bone immediately releases growth factors. And then we take the blood 20 minutes later before we do the augmentation. And we use now the growth factors to activate the BioOS, the DBBM.
The material. Good.
So actually then the whole augmentation material is enriched with growth factors. So this is then the contour augmentation as we see that. So this has been documented very nicely in the last 9 years with in vitro studies, also tissue culture studies, cell culture studies. And I'll show you only the last one, which was published in a Chinese journal. You see by Asparuova and Jordi Cabaye. You see here, you see how the whole thing was done. And here you see the most important results, that you see an instant release of TGF-beta 1. And slightly delayed, you also see then a peak of BMB2. Both are potent growth factors for the formation of bone. And when you summarize that, this is a very nice graph by Maria Asparuova. You see on the left side, you see the TGF-beta 1, which is a proliferation factor. So
Yeah.
this activates mesenchymal stem cells from the bony walls to grow into the defect.
Good.
And when the cells are there, then the BMP2 is then here to differentiate them and to stimulate the mineralization of the osteoids. So these are
it's a safe
all
way
set
to
up.
improve the quality of the material.
Absolutely. So you get faster bone, you get more bone. That's very important in a very crucial area. Okay, here now you see how this is done. That's our patient we have seen before. So here first the blood collection and then the collection of autogenous chips with a booster scraper from Hufredi. And then very important, you have to keep that scraper sharp. So you have to resharpen those scrapers from time to time. They should not be dull. And then we prepare the implant bed. And then you see here the preparation of an implant bed. In this case, we are used parallel walled bone level implants.
Yeah.
We also see here very nicely that when there is a thin bony walls, I normally take those off because it will be resolved anyhow. So I round off the edges here very nicely.
That's good.
Then we put the implant in, and very important that the implant goes with the implant shoulder always below the palatal bone wall. So we have there no exposed micro rough implant surface in the future. Here you see that, sorry, it's covered by my hands. So here you see it now here beautifully. So we are below the crest, and that's very important. Okay, now comes the bone augmentation. So here you see again that we take the aspiration of this blood ringer solution and we use it to activate the second filler, which is normally BioOS. Then we do the autogenous bone application here inside first, and then a second layer with the activated DBBM particles. And then we cover it up by a collagen membrane. Has to be collagen membrane, so there is no need to go back in to remove the membrane.
Okay.
So that's how it is done. Okay, now we go ahead. You see now here the membrane gets applied. Again, BCM blood. It's called bone conditioned medium blood with the growth factors go on top. And you see then very nicely how it's adapted. It's no need for tax in a case like this.
I was about asking that if
No,
you
you
fix
see
the membrane or good.
the stability of this filler is more than sufficient. All our long-term studies have been done without tax. I use tax from time to
Without
time in the
good.
mandible. When the fillers have a tendency to glide off, then of course it's important. And then last but not least, then we do a primary closure. The flap has to be released and mobilized with a periosteal incision, so it's tension-free and so on. So you see these surgical videos here, the clips are from a master course. We are having two of them in Bern every year, one on GBR and one on aesthetics. Okay, here you see the
Yes,
patient.
I've been there several times.
Yeah. You see, that's a good investment actually. You see here now, 2 months post surgery, then we do the reopening, and then I gave the patient to Professor Belzer, and he did a provisional crown for soft tissue
Perfect.
conditioning. And here you see, of course, a fantastic outcome. This is 2.5 years later with a really beautiful
Very beautiful.
aesthetic
Congrats.
outcome. Professor Belzer loves this lady. It's a beautiful aesthetic outcome. It's a young patient, of course, because of a post-trauma situation. Okay, here's another cases where we have used BCM, and here we have even a cone beam after 3 years. You see, two missing central incisors, same technique. See quite significant defects here, autogenous bone, BioOS, BioGuide, primary closure. 3 years later, the results, and you see here the periapical, you see the bone in between. If this peak, that's the important area for the central papilla. But here you see how we have been able, that the patient, of course, the body of the patient formed the bone then during the first 2 months of healing.
Sure. Great.
So,
Great. A typical contour augmentation
yes.
from Bern. I mean, the typical case. So it's like a signature from you, from your team. You always. I mean, I will always. It's the. I see this kind of lectures from you many times, and it's always great to rehear it. To strengthen these concepts. And what's your long-term experience on these procedures?
Yeah, we of course we know that you can always show nice cases. When you do 100 cases and you have 10 nice cases, you can do a lot of lectures. But of course, that is not the reality. So the reality must be that you publish the data, and we have done a major efforts in that field.
Of
And I
course.
show you quickly, these are all the publications on early placement with contour augmentation. And of course, we started in 2008 with short term. We had 2 patient cohorts in that group. And lately, here the paper by Chapuis, this in Journal of Dental Research, again in top-notch journal, we were able to present the 10-year
Yeah.
data in a prospective case series study. So this
10
is the
year
paper.
10-year data. So
Yeah, it's only
there's
20 patients, but all 20 patients have been followed for 10 years in a row. And you see, when we concentrate on the facial bone wall, you can see that in 14 patients, so 70%, we had a fully intact buccal bone wall, and the peak of the facial wall was coronal to the implant shoulder.
good.
In
Good.
5 patients, we had an intact facial wall, but we had the most coronal part of the peak was slightly below the implant shoulder, and we call it always Mrs. M, because she was when we counted in the papers one patient where there was a lack of bone, so she did
Yeah.
not form the bone. This case was considered at 6 years, and at 10 years a non-successful implant case because we did not get the facial bone wall. Clinically, the patient is not a failure yet, but we will see if we get into troubles with this. And this is the original table from the paper that shows, you see that the mean thickness of these 19 cases was 1.7 millimeter at 10 years of follow-up. Now you have to consider
Good.
we did not know anything about BCM. So in the later cases since 2014, 15, we see even better results, but I'm very pleased with the data after 10 years. And I can show you now some of these long-term cases. This is one of the 10-year cases from that study.
Okay, that's from that
We
group.
showed in
Good.
our paper in 2008. You see here the whole procedure, and you see 10 years later, you see excellent outcome, and you see no bone loss around these platform switching implants. And here you see the facial bone wall fully intact. So this is a very nice case. Then we have another one. This is a very interesting case. I treated 3 times. You see here, it started in 2009, a post-trauma situation, and you see huge defect. And then I pulled the tooth, and then we did the typical early placement with contour augmentation. So you see same procedure, primary closure, and then she lost another tooth, not next door, just the lateral incisor to the right side. So we had a second surgery in 2012, and you see we have done the same here again. Now she has 2 implant crowns, and you see here then the third surgery in 2018, when then she lost the tooth in between. So we had to pull that tooth because she developed an apical lesion, and then we converted 2 single crowns into a 3-unit bridge. And here we have done a socket grafting and a full thickness graft to maximize the amount of soft tissue in the pontic area.
It wasn't one narrow implant and one regular
Yes.
implant,
And
no?
here's so this is now the patient you see 11 years post first surgery. That was actually right a few weeks ago. You see now a 3-unit bridge, and you see she has a very gummy smile. You see
Very nice.
very nice. And very interesting is that actually we did not lose too much bone following the extraction, just a little bit. So I'm very happy with that treatment outcome, and it shows the whole potential of GBR.
Tough smile, to manage.
Yeah, she's very beautiful, by the way. You see, young mommy now. She's 40. Young mommy now. She's 40 years, just got a baby. And here now you see another one where we have 2 central incisors. Very important, this one, when we have 2 adjacent central incisors, we do bone level implants, and we try to augment here as much as possible also here to support the soft tissues. And you see here then, of course, then the primary closure, and then spells the deeper crowns. And here you see then the restoration. And here you see the lady 11 years down the road. So beautiful, look this one.
Perfect.
Look the facial walls. So very pleasing outcome.
Good.
Okay, last
Really
case
good.
I want to show. This is a case, the first one we did in 1998. You see, first time we did this 2-layer composite graft, and you see here the whole procedure, and you see the primary closure, and here now you see the lady 20 years down the road. It was in 2018. She's from Zurich and comes every 5 years to Bern to see me. And then here you see the periapical, and here you see the facial wall. So that is a very nice proof that long-term stability is a reality, but of course we need to have many cases for 10 and 20 years then in the future. Yeah, this is the long-term documentation we have.
So clearly it's your favorite procedure, your favorite protocol. You feel safe doing that. I mean, it's a good message for the dental community to be on the safe side, to choose this kind of procedure or this protocol to avoid any complications, especially in aesthetic zone that it's...
Yes. Now I want to say the following. If you are a specialist and you do tons of implant surgeries, then of course you should also have in your treatment options the immediate implant placement.
Yeah, for sure.
And use the procedure what I showed. Then it's very nice. That will be 5 to 10% from my point of view. And then you have 80 to 85%, you have then early placement, because the reality to have there a thin wall or a lack of bone is so frequent, then you cannot do immediate implant placement from my point of view.
For sure.
If you don't do a lot of implant patients, you see, so you do your 20 cases, then I would not go for immediate implant placement. Just stick to the early placement protocol, because it's less problematic and it's more forgiving. So that's just my message.
I took a little question from the audience. They asked for which kind of membrane do you use in this protocol. I know that it's a collagen membrane, and
Yes.
how many weeks are the barrier work, and how many weeks does this kind of membrane stays in place?
Okay, you see, you have to change your way of thinking, because you have to think biologically. Because 20 years ago, I was thinking you need a membrane that stays there for 6 months. Today, I know that's absolutely wrong. When you have a defect like this, like in an early placement, the cells to form the bone, they move into that defect in the first couple of days, and within 2-3 weeks, the whole healing is initiated. You have the woven bone and so on. And then only maturation steps take place. So you don't need a barrier function for 3 months or so. This is complete nonsense. This is just more knowledge we have today.
For sure.
So this is a collagen-based membrane. It's a wound draping, so it keeps the fillers in place, and it gives you in the first 1 or 2 weeks, gives you then a barrier function.
Absolutely clear.
And it's part of the tissues, and it will be resolved after 4-6 weeks, I guess. Nobody knows exactly in humans. We know it from animal studies that it can be there still some remnants at 8 weeks, but in humans nobody knows. Nobody knows, because we cannot take human biopsies for obvious reasons.
For sure. And there's nothing to protect.
No need to do
the
that.
surgery. That's good.
But of course, you have to understand, you need autogenous bone to really speed up this segmentation. You see.
Exactly.
It's the critical point.
Yes, to add those factors that you share with us. So if you agree, we can move to the last option.
Yes, last option.
The late implant placement. Do you use
implant placement in the aesthetic zone?
In the aesthetic zone.
Really
Do you use this approach very often, or just in special cases, or?
In special cases. I mean, I have only 4 patients like this. 4 patients. So these are either periapical big lesions like a cyst, or it can be a young patient who has to be removed for trauma reasons, and then you have to wait. So then what we do, we take the tooth off, do a socket grafting, and wait until we can place the implant. In a cyst lesion like this one here, then you go back in at 6 months. When it's a young patient, adolescent, you wait until the patient's 20 years old.
It's a smart decision, for sure.
That's how it's done. And I show you only one case which have been shown many times. You see here, you see the cystic lesion, and you see how I took the cyst off. We had to do an apicoectomy also at the lateral incisor. There was actually a defect in the floor of the nose from the cyst. And we did a rich augmentation area in the area of the future implant with a membrane and everything. And then we let it heal. And then I went back in at 6 months to do the implant surgery. You see here the surgery with the implant placement, and you see then a submerged healing, 2 months of healing, and then Julie Wittneben took over and did then an implant, a crown. And here you see now our patient 6 years down the road. You see again, no sign of bone loss, because it's a platform switching implant. That's the way how we do the crown. So it's a very slim development of emergence profile. We are not using these special apartments, because then you lose bone. That's not how we do that. And here now you see here, look, this one, 6 years down the road. Also excellent bony architecture for the implant restoration.
So just to strengthen the idea, you prefer this switch platform concept in the static zone, especially
Yes.
when you have to deal with a long emergence profile, 6 millimeters, 7 millimeters in the proximal area. You consider this kind of connection much
Yes.
more stable than
Yeah.
than others. Good.
You lose less bone. There is a paper by Vivian Chapuis to compare tissue level and bone level implants in the aesthetic zone, and you clearly lose less bone on the facial aspect. So, in single tooth cases and in tooth central incisor cases, we strictly use bone level implants when there is enough bone on the palatal aspect. Tissue level implants we use sometimes when there is a bone deficiency on the palatal side, and then the bone level would have to be placed very, very deep to get the implant with the micro rough surface below the crest. But we are waiting for the bone level implants with a machined top. And when this will be available, then we're going to use in the aesthetic zone only these bone level implants, either BLT or BLX. I don't know because I have not used yet BLX implants or the bone level implants, just the routine ones.
But and you are I mean, just think that tissue level implants are absolutely restricted, more not in that particular case that you told me, but only for posteriors. I mean,
I'll,
you still do your tissue level implants on posteriors. I mean,
Okay, tell you frankly, 80% of implants I use are tissue level implants because it's a hybrid design implant, because it has a machine surface, and the machine
yeah,
surface in the transcrestal area is
great.
minimizing the risk factor for the development of peri-implant pathology. You see, the micro rough surface can be a risk factor for biofilm attachment and then for peri-implant mucositis or peri-implant bone infection or the peri-implantitis.
Good. Well, to sum up all of these concepts, these
Yeah.
three possibilities, this invaluable concept that you share with us today, which are the main take-home messages. People are at home, but they will take it to the office. But what are your main conclusions on these options?
So when you summarize this whole,
Take the microphone, Danny, please. Again.
I'm sorry. Yes,
Good, good.
I have. I have to buy a holder, you see, for myself
That's good.
for future Instagram.
You're an influencer now on Instagram, so you should take your new tools to be in connection with people. That's good.
I have
Go
to
on, go
find
on.
one. I don't know where you get it. Okay, the conclusions. First one. When you do implant placement in the aesthetic zone, you need to understand the biology of the tissues. The resorption of bundle bone is a biologic phenomenon. It's in the genes of these cells. You cannot change that. When you do an extraction, you always lose bone. Even in an immediate case, can be 1 to 1.5 to 2 millimeters. Can be compromising. This resorption must be compensated with a local contour augmentation when the facial bone is resorbed. And this is an important structure for the aesthetic outcome. Second one, as a clinician, you have different treatment options in post-extraction sites. And I tell you frankly, I use them all with pleasure. So I try to do the procedure that gives me an excellent outcome with a low risk of complications. So when I have a low risk case, a thick facial wall, everything is perfect, then I try to do immediate implant placement, but only then. So the clinician should choose the treatment approach that gives him a high predictability for successful aesthetic outcome and a low risk
A
for
low risk. Good.
complications. And the treatment of choice depends not only on the anatomic risk factors, but also on the skills and the talent of the clinician. That means there are colleagues, they should not do immediate implants because they don't have enough patients to build up this experience. So
Good.
that is a very important message as well. The
Go.
third one is immediate implant placement should be done by master clinician, great skills and experience, lots of patients, because it's technique sensitive. It has to
Okay.
be done. It has to be done only with a thick wall phenotype. Should be done flapless. Should be done computer assisted, so you can control the
Oh, to
axis.
be on the safe side, that's good.
Very important. And then it's a very attractive treatment options. It's actually the most attractive one for patients. Huh? Next one is, you see, when there is a damaged wall or a thin wall, then don't do immediate implant placement. You take a
Good.
risk that will bite you in 3 to 5 years. So then go for early placement, rebuild the bone, go for a membrane application, two-layer composite graft, primary closure. So you should not go for immediate restoration. The bone has to grow all the way up to the shoulder, and there's no space there for an immediate restoration.
Good.
The long-term data is excellent. You see the autograft accelerate the bone formation, and the BIOS, you see, gives you long-term stability because it's a low substitution rate, you see. Okay. Last point, late placement, that is the least attractive one in the aesthetic zone, only when it's necessary. Young patients or cystic lesions, what I said. It helps to avoid that you get a lot of significant resorption to go for staged approach later on. But as I mentioned already, this approach is not often used in the aesthetic zone. So
Good.
soft grafting is not done in aesthetic sites when we can go for immediate or early placement.
Good.
So you see, you have all these options, and you choose that one gives you the best chance and the lowest risk, as I mentioned before.
That's a good final message. So we have 5 minutes to go. I want you to speak your mind regarding what's in the near future. I mean, what's your thoughts, what's your ideas in the near future in terms of community, in terms of dental communication, how this virus issue are affecting our behavior in
I think,
clinics,
of
in
course,
teaching.
it's very obvious. This virus crisis or pandemic will increase the digital technology for the knowledge sharing. You see all the major associations move into that direction. Of course, I will do also a contribution to that. Probably we will do this kind of Instagram lecture once a month or so with a hot topic, and then we share the knowledge. As you have seen, of course, I learned quickly from our youngsters here. You see the Facebook group I have already for 3 years now, and I'm impressed to see that after the means we actually signed up for this Instagram lecture that we acquired another 800 members to the group, you see. So this is an important one. Here we share cases, we share publications, and so on. And then, of course, I just learning how to use Instagram, but we have acquired here 3,000 followers in 1 week. So we will see. I will probably here announce stuff, what is on Facebook, a new paper, a case report, a video clip or so. And then the third one, that's also an important one, that's a YouTube channel I have established about a year ago. You see, called the Booster Implant Team. We have here also more than 400 colleagues. And we are putting here now short versions of lectures. We're putting here short video clips of our procedures and so on. So this is also a very nice way to do that. Of course, I hope that in the future, the travel will not be restricted anymore. We want to do our master courses. Again, you see one is still scheduled in the beginning of September. I don't know if this will take place. The GBR master, and probably the most prominent one, sold out for many, many years now, all the time, mid-June, has been already postponed to November because June is impossible in Switzerland.
For sure.
And we have already there more than 40 people signed up. So we changed the date. I think 3 dropped off. The rest will come in November now. And we start to push this, of course, in the next couple of days.
So did you enjoy this new tool to share
Yes,
with the.
absolutely interesting. Of course, you are a fantastic moderator. You see, you are a smart
Okay,
guy.
thank you.
I think what I have to do, I have to find a holder. So then actually this will be on my desk and I only have to switch from the back to the rear camera and then we can do that. But actually I like it very much because
Good.
you can move in here, you see, and you can show something and you move out again. So actually this is quite interesting, you see. So I'm sure we're going to do it again.
Good, good, good. We will
We are on
improve.
time, by the way, huh?
Yes, we are perfectly on time. Please, as soon as we ended the session, please put it on your storyboard so people can take a look on the take a look on this